In the West, vitamin B12 deficiency occurs in up to 40% of diets because people often consume a low level of vitamin B12 rich foods. In extreme cases, this deficiency can produce neurological and hematologic signs and symptoms. However, low or marginal vitamin B12s, 200 to 300 picograms per milliliters, in asymptomatic individuals is far more common. Let's look at one of these questions. Which of these risk factors is more commonly recognized for vitamin B12 deficiency? Is it alcohol abuse, radioiodine ablation of the thyroid, frequent consumption of organ meat, or IBS? So the answer here is alcohol abuse. The known risk factors for vitamin B12 deficiency include any person older than 75 years old, strict vegan or vegetarian diet, alcohol abuse, and mostly GI related issue like atrophic gastritis, Crohn's disease, ileal resection, pernicious anemia, post-gastrectomy syndrome, tapeworm infection, and trans-cobalamin 2 deficiency. So from the answer choices, organ meats, this includes liver and heart. Actually, they are known to contain high amounts of vitamin B12. For another choices like radioiodine ablation of the thyroid, this has not been found to cause vitamin B12 deficiency. Let's move on to our next question. Screening may be warranted for vitamin B12 deficiency in patients taking which of these? A. Metformin for more than 4 months, losartan for more than 3 months, duloxetine for more than 6 months, or having taking daily aspirin for more than 12 months. So the answer here is again A. Metformin for more than 4 months. Although screening average risk adults for vitamin B12 deficiency is not routinely recommended, it may be warranted in certain populations, and these include people who are taking metformin for more than 4 months, or taking proton pump inhibitors, or histamine 2 receptor antagonists for more than 12 months. Although the causation has not been definitive, an association has been observed with this medication used over these durations. Let's move on to the next question. Which of these symptoms is more commonly recognized as a potential clinical manifestation of vitamin B12 deficiency? Is it A. Prolonged constipation for more than 7 days, eczema, glossitis, or D. Urinary retention? So the answer here is C. Glossitis. Vitamin B12 deficiency is more common in older adults because of dementia, strict vegetarian diet, poor nutrition, and lack of access to care. Other common presenting symptoms may include signs of anemia, such as pallor, fatigue. You also get glossitis, the answer choice in this question, diarrhea, jaundice, peripheral neuropathy, headaches, and neuropsychiatric disturbances. Let's move on to another question. Which of these statements does the American Academy of Family Physicians AAFP recommend in the diagnosis and treatment of vitamin B12 deficiency? Is it A. Use of vitamin B12 supplementation in patients with elevated serum homocysteine levels and cardiovascular disease reduces the risk for myocardial infarction? Initial lab analysis should routinely include methylmalonic acid assessment in patients with suspected vitamin B12 deficiency. C. Patients who have undergone bariatric surgery should receive oral vitamin B12 supplementation indefinitely. Or D. Oral administration of high-dose vitamin B12 is vastly inferior to intramuscular administration for correcting anemia and should be avoided. So the correct answer here is C. According to AAFP, Patients who have undergone bariatric surgery should receive oral vitamin B12 supplementation indefinitely. However, screening all average risk adults for vitamin B12 deficiency is not recommended. In patients with cardiovascular diseases who have high serum homocysteine levels, vitamin B12 supplementation does not reduce the risk for myocardial infarction or stroke. The other answer choice about initial lab assessment. The initial lab assessment should include a complete blood count and serum vitamin B12 level. Serum methylmalonic acid assessment should be used to confirm vitamin B12 deficiency in high-risk patients with low to normal serum levels of vitamin B12, but this is not a part of routine lab screening for all patients. Intramuscular and oral administration of high-dose vitamin B12 both correct anemia. However, intramuscular therapy offers more rapid improvement and use for patients who have severe neurologic symptoms and severe deficiency. Lastly, let's move on to the last question. Which of the statements is most accurate concerning cyanocobalamin in the treatment of pernicious anemia? Is it A, vitamin B12 treatment can be through oral, intranasal, subcutaneous, or intramuscular routes? B, cyanocobalamin treatment should be held until polycythemia test results are available. C, oral and intranasal routes are preferred except in most severe cases. Intramuscular and subcutaneous routes are used until symptoms resolved. So the answer choice here is D. Oral and intranasal routes are not indicated for treatment of pernicious anemia until symptoms resolve, no signs of nervous system involvement remain, and the patient achieves hematologic remission. Before that time, intramuscular and subcutaneous routes are used. Holding treatment for vitamin B12 deficiency to test for polycythemia vera is not necessary. Treatment for vitamin B12 deficiency may uncover the issue. Lastly, patients who exhibit hematologic or clinical responses consistent with polycythemia vera should be evaluated further.